عليكم. Our lecture today is about gestational trophoblastic disorder, a very important subject, gestational trophoblastic disorders. What is the definition? It covers a spectrum of disease caused by trophoblastic proliferative abnormalities. This include hydathiform mole, choriocarcinoma, invasive mole, and placental site trophoblastic tumor. What is the incidence rate? Incidence between 0.5 up to 2.5 per 1,000 pregnancies. Backgrounds. They found that 50% of cases follow hydathiform mole, 25% a normal pregnancy, and 25% follow miscarriage or ectopic pregnancy, i.e. يعني إذا أخذنا 100 كيس of hydathiform mole تقريبا نشوف أو كوريوكارسينوما 50% هو follow hydathiform mole، بس يمكن نلقى أكو 25% من الكوريوكارسينوما أو الجستيشنال trophoblastic disorder follow a normal pregnancy or يعني even after miscarriage or ectopic pregnancy there is what we call gestational trophoblastic disorder. First of all, to talk about hydathiform mole can be subdivided into complete hydathiform mole and partial hydathiform mole based on what? On genetic and histological feature. يعني عندنا صفات وراثية وصفات نسيجية. Incomplete hydathiform mole pathogenesis. Either we have an emetoocyte fertilized by normal haploid sperm 23X, which duplicate itself to complete 46X. يعني عندنا oocyte فارغة تتلقح عن طريق نطفة 23. هاي النطفة تسوي دوبليكيشن، تضاعف نفسها، فتحصل لك الكروموسوم بالعدد الثابت. اوكي after meiosis. وهذه it is more common occur in 96 or less commonly عندنا emetoocyte يعني فد بيضة فارغة من المادة الوراثية تتلقح عن طريق what we call it dispermic process اللي هي 23Y or 23X leading to what we call 46XX or 46XY, and this is occur in minority of cases of hydathiform اللي هي 4% of cases. Karyotype. الكاريوتايب هم يكونون 40XX or 40XY وهنا pure paternal contribution. Why? Because we said there is emetoocyte يعني we have no genetic material from the mother. Phenomena of androgenesis. The microscopic feature, what you are going to see by your eyes. Bunch of small clear grapes and no fetus. The microscopic features under microscope: diffuse hydropic swelling, diffuse trophoblastic hyperplasia, absence of blood vessels, and no fetal tissues. Partial mole. الباثوجينيسيس هنا يكون either fertilization of normal oocytes يعني المادة الوراثية 23X by two sperm or fertilization of normal oocyte by single sperm failed to undergo meiosis يعني السبرم راح تجي جايبة وياها 64 ما صار بيها انقسام انشطار فcarries maternal load of XY result in triploidy 69 chromosome with double maternal contribution يعني here there is contribution from the genetic material from the mother and the father. That's why there is fetus in this type of HMOL. The karyotype 69XXY in 70% and 69 XYY or 69XX in 27%, or double maternal contribution in 69XX اللي هو 3%. Macroscopical feature, what you are going to see by your eyes. There is fetal, عرفنا السبب ليش. And placental tissue in the fetus, there is intrauterine growth restriction, cross anomalies like hydrocephaly. الميكروسكوبيك features هناك كل شيء diffuse، هنا لا focal hydropic swelling, focal trophoblastic hyperplasia, presence of some blood vessel and fetal tissue with gross anomalies. Epidemiology very important in gestational trophoblastic disorder. Regarding ethnicity, it is more common in Asian than Western women like Japan and Korea. The maternal age very important. Women older than 45 years had increased risk, and the women younger than 15 years had increased risk, but less than for older ones, so extremity of age is a risk factor. Why? Because whenever the patient or the woman it is become older, so the percentage of abnormality of chromosome it is increased. That's why, and because the hereditary hormone is the disease of a chromosome, that's why it is more common when the maternal age is increased, i.e. chromosomal aging. Diet and socio-economic factor. Diet low in carotene, vitamin A, and low animal fat had high risk also related to protein, folic acid, and iron deficiency، لأن كل هاي المادة الفوليك أسيد والأيرون والبروتين تدخل في تكوين المادة الوراثية اللي هي DNA، وصحيح والدي ان اي كلش مهم في بناء الكروموسومات. يعني إذا كانت ما عندنا مادة سبستريت لبناء حامض نووي جيد فأكيد راح يصير عندنا هذا الديزيز. فالدايت very important. blood groups. maternal blood group B AB are risk factor، بينما شافوا group A are protective. previous molar pregnancy there is an increased risk of recurrence and the overall incidence is between 0.5 to 2%. يعني any previous هو increased risk. The genetic factor occur in certain family cluster and cases of repetitive more. يعني إذا كانت مريضة عندها أكثر من مرة تفكر إنه هذا genetic factor، لأنه نرجع ونقول it is a disease of chromosomes. How is the patient presented to you? Exaggeration. Sign and symptom of pregnancy depend on the proliferative activity of molar tissue. Very rapid growing tumor, very active. طبعا المين presenting symptom اللي هي 90% of cases presented with vaginal bleeding irregular in first trimester. Uterus large for date، يعني تقريبا البرسنتج 25% because the uterus filled with molar tissue، يعني يملي بالmolar tissue. البين لا البين from large theca luteal cyst اللي هي 20%. Why? This occurs من ovarian hyperstimulation by high level of HCG level. HCG يعني because there is increased molar tissue فincrease، يعني نعرف احنا ال HCG ينفرز من التروفوبلاست cell. Because of increased trophoblast cell number there will be increased level of HCG. Exaggerated sign and symptom of pregnancy. يجي المريض عنده أنيميا. ليش أنيميا؟ أولاً rapid growing tumor، فياخذ عندك ايرون ياخذ شيء. بعدين من البليدنج، صح ولا لا؟ مريضة عندها بليدنج فتصير أنيميا. والسبب الآخر إنه البيشنت عندها هايبر إمس جرافيدارم فما تقدر يعني تاكل. فثلاث أسباب للأنيميا. أولاً because it is rapid growing tumor. Secondly because the patient is bleeding. And thirdly because the patient does not eat because of hyperemesis gravidarum. Hyperemesis gravidarum وعرفنا السبب because high level of beta HCG. Hyperthyroidism in 5% of cases. Why? لأنه عندنا sharing the same chain between beta HCG and TSH، تكون عندهم الألفا chain مشتركة. early preeclampsia very important. يعني if you face patient less than 20 weeks وعندها preeclampsia you have to think by molar pregnancy. Mobilization. The molar tissue may escape the uterus through venous outflow and emboli may reach the pulmonary vessels, leading to fatal pulmonary embolism. DIC, molar tissue, may release thromboplastin to circulation and stimulate fibrin and platelet deposition, leading to DIC. لهذا you have to take molar seriously because it is caused two fatal complications, embolism و DIC. How I am going to diagnose? أكيد إنه by ultrasound اللي هو show the characteristic snowstorm appearance and large thecal luteal cysts, incomplete hydatiform mole, and in partial mole fetus may be viable with sign of growth restriction and structural abnormalities. طبعا the quantitative measurement of serum beta HCG no longer used unless the ultrasound is يعني unequivocal. شنو aim of treatment of hydatiform mole? The aim of treatment, this is an abnormal pregnancy, so I have to eliminate all molar tissue from maternal system. This is one, without any due delay, بدون أي تأخير. I have to do preparatory step prior to molar evacuation. I have to prepare blood because there is risk of bleeding. I have to send my patient complete blood picture, coagulation screen, electrolyte check, correct anemia, DIC, and electrolyte imbalance. Correct dehydration, which may result from hyperemesis. You have to perform chest X-ray at the time of evacuation to exclude lung metastases. Treatment of preeclampsia. This is the general treatment. We have a specific treatment. The treatment of H-mole, we have two phases. اللي هو immediate phase اللي يتضمن evacuation of mole والfollow-up phase to what? To detect the malignant changes. لأن قلنا هذا يمكن يتحول إلى malignancy. Immediate phase. شنو immediate method of evacuation of mole? Section curettage. Vacuum aspiration using negative pressure between 60 to 70 centimeters mercury. It is the safest and preferable method and can be used even the uterus larger than 20 weeks. This is usually undertaken under GA to allow easy cervical dilatation. Oxytocin drip should be avoided during evacuation of mole because there is theoretical risk of molar tissue dissemination. يعني أكون خطورة نظرية leading to metastasize to the lung and the brain, but its use may be important to reduce the risk of bleeding. We can be used after complete evacuation. يعني من خلص complete نقول لهم يعطونا بيتوسين على مود يسوي لي contraction to the uterus. The bulk of evacuated mole should be medical legal sent for histopath examination to exclude what persistent trophoblastic disease. Uterine stimulation by oxytocin and prostaglandin are poor alternative to section curettage because why? The IV oxytocin as a primary method of evacuation of mole is unsatisfactory because myometrial response is poor and need long hours of stimulation during which period metastasis may take place. يعني بخطورة انه انت المصل مالت اليوترس ما راح تستجاب للفيتوسين بالمولر بريجنسي. السبب الثاني تحتاج فترة طويلة على تسقط المريضة وبالتالي راح تخلي اكو فرصة انه يصير عندك ميتاستاسايز المولر تشو وتنتهي المريضة بديزاستر كومبليكيشن. Prostaglandin E more effective to stimulate uterine contraction and is the safe especially in the presence of coexistence fetus in partial mole. يعني rule of misoprostol or prostaglandin is just in case of partial mole. Hysterectomy, is there any rule of hysterectomy? Yes. It is indicated in women over 40 years, complete her family and desire sterilization. Here, hysterectomy may be preferred because in such age group, around 40% اللي هي نسبة كلش عالية develop malignant changes later on. So, hysterectomy is usually associated with lesser number of subsequent chemotherapeutic courses. Emergency hysterectomy may be indicated in certain circumstances for controlling massive, life-threatening hemorrhage. Is there is any need for removal of ovary? Depend on patient age. If more than 50 years, so remove. If less than that, so retain even in presence of thecal lutein cells لأنه thecal lutein cells will regress spontaneously after you evacuate the all the molar tissue after normalization of beta HCG level. What is the complication? عندنا immediate complication or remote complication. Massive hemorrhage لهذا قلنا you have to prepare blood. Sepsis you have to give antibiotic. Preeclampsia may severe enough to develop fit eclampsia. Remote complication include metastases and malignant changes. شافوا 80% of identiform mole undergoes spontaneous resolution after contact يعني ما عندنا أي مشاكل. وقد عندنا 15% develop local invasive mole لهذا احنا لازم نسوي هيستوباث لأن هذا احتمال invasive mole. 5% develop metastatic. 5% develop metastatic choriocarcinoma. 5% of partial mole develop local invasive mole. Follow-up phase very important. يعني for 2 years تابع مريضتك سنتين after evacuation of mole to identify تقريبا 20 to 25 who will develop malignant changes or metastasize, and the rationale of follow-up is شنو السبب؟ to ensure that those who require chemotherapy should receive it. أنا بدي أطلع المرضى اللي هم محتاجين تعطيهم chemotherapy and when it is effective are not given to those who do not need it. ونطلع المرضى اللي هم ما يحتاجونه. Second curettage, اكو rule for second curettage in management of identiform mole may be needed, maybe يعني مو شرط. If bleeding persists 2 weeks following first evacuation because of incomplete uterine emitting but is not routinely recommended. يعني احتمال انت ما منظف الرحم زين فتحتاج تعيد له بس it is not routinely recommended. نحكي عن contraception. Contraception قلنا البيشنت should be not become pregnant for at least 2 years. Prevent pregnancy for at least 1 to 2 years because it results in HCG which cannot be differentiated from that produced by persistence or recurrent gestational trophoblastic tumor. فإحنا ما نعرف هذا ال HCG هو من الحمل من ال persistence gestational من ال recurrence مالتها. The patient should avoid pregnancy at least for 1 to 2 years. The different type of contraception have different effect on moral tissues. The IUCD not advisable at all because it is increasing bleeding and may perforate the uterus. The combined oral contraceptive pills alter the behavior of a trophoblastic cell and prolong their biological life and make them die slowly. But this is not the case with low-dose pills less than 30 microgram estradiol. الميني pills causes breakthrough bleeding نفس الشيء which confuse the clinical picture. So the best contraceptive method is the barrier method or low estrogen pills until normalization of HCG. يعني من يصير normalization تقدر المريضة تاخذ الcontraception اللي هي تريده. Serial HCG level very important. This is essential in follow-up to identify malignant potential group. Routine assessment of HCG assay started 3 weeks after evacuation. أول مرة بعدين 2 weeks interval and should be normalized خلال 4 to 6 weeks after evacuation. After reaching normal level repeat at monthly يعني كل شهر نعيده for the first year and 3 monthly interval for the second years. Continue surveillance for 2 years بالنسبة للcomplete mole و for 6 months in partial mole. إذا أعيد بالنسبة للبيتا HCG نسويه ورا 3 أسابيع ورا الايفاكويشن بعدين نسويه كل اسبوعين لحد ما يصير عندنا نورماليزيشن بعدين كل شهر خلال السنة الأولى بعدين كل 3 أشهر خلال السنة الثانية. Okay. Chest X-ray recommended at time of evacuation of uterus repeats monthly until normalization of HCG then repeat at 6, 8, 12 months. But if initial chest X-ray is normal and HCG decrease, no need to repeat it. Indication for chemotherapy. Now, what is the patient who are going to take chemotherapy? The task of follow-up is to identify the need for chemotherapy, which are أولاً first post-evacuation HCG level more than 20,000 international unit per liter in the blood and 13,000 international unit per urine, which means that there is a high malignant tissue. So we have to give beta chemotherapy إذا كان عندنا high level of beta HCG. Abnormal HCG curve we mentioned in the beginning of the lecture إنه normalization تكون within 4 to 6 weeks after evacuation. So failure to normalization within 6 to 8 weeks after evacuation. Increase HCG level at any time يبدي يصعد معناته التيومر بدأ يصير بيه recurrence. Plateau of HCG for 3 weeks يعني معناته الكانسر سيل قوية. Evidence of إذا كان عندي evidence of GIT and hepatic or intracranial metastases I have to get. Pulmonary metastases هذا بوحده with increased HCG you have to get. Persistent hemorrhage with increased HCG. Any detectable level of HCG after 5 to 6 months after evacuation. يعني مثلا كله نورمال هناك ورا 6 أشهر لقينا الليفل صارت مثلا 200 you have to give chemotherapy. If any indication of chemotherapy detected the mentioned above, patient should be referred to specialized center for consideration of chemotherapy and choosing appropriate protocol according to the certain criteria. If none of indication detected in 2 years, period, follow up, reassure patient and encourage pregnancy. This is ultrasound scan of hydatiform moon. Look for a snowstorm appearance. عاصفة ثلجية. This is the picture of invasive moon. This is show the mole how is the uterus is full over by the mole. This is a macroscopic specimen. We see the hydatiform mole. This is another ultrasound picture for hydatiform mole that show you the snowstorm appearance. This is pelvic examination. This is the histopath. Look for the diffuse. And this is different picture show you that. And thank you very much.